afternoon, everybody. Thank you for joining us for today's special series, Echo Clinic. So great to have you all out there. Christine, do you want to go ahead?
Yes. Hi, everyone. I'm Christine Thompson with Nevada Cancer Coalition. I'm the Community Programs Manager here. Troy, do we have our slides?
Yeah.
Thank you. So Nevada Cancer Coalition is the statewide nonprofit. We bring together organizations and individuals from across the state to work on all things cancer. We provide information and education to both the community and to healthcare providers, and our website houses the state's most comprehensive cancer resource directory. Our coalition develops and implements programs on cancer prevention, early detection and screening, survivorship initiatives, and we do lots and lots of advocacy work, particularly advocacy work around policy surrounding cancer and ways to improve the delivery systems for people living with cancer. If you haven't yet taken the opportunity, I encourage you to take a look at our website. There are lots and lots of wonderful resources there for healthcare providers, easy to download, easy to access, and we all are at your service to work with you. We are so grateful to Project Echo and to Dr. Mannering to collaborate with us today to offer this clinic on skin cancer. It's Skin Cancer Prevention Awareness Month, and so the time is right. I should advance. Skin cancer, as most of you probably know, is the most common cancer in the United States. Rates are rising. More than 5 million people are treated for skin cancer every year, and in the United States, 9,000 people are likely will die from melanoma this year alone. In Nevada, it is estimated there will be 850 new cases of melanoma diagnosed this year, and 90 people will die from melanoma. We want to change the statistics. SunSmart Nevada is the Nevada Cancer Coalition statewide program that is a response to the 2014 call to action from the U.S. Surgeon General to prevent skin cancer. This program works to implement sun safety policy and education in schools, workplaces, and outdoor recreation area while promoting outdoor exercise and activities. Thank you, yeah. SunSmart Schools is the youth component of the statewide program. We recognize that the importance of building healthy sun safety habits while we're young, and in 2014 we began a 7-school pilot program in 7 schools touching students from pre-K through high school. That program has since grown to now include nearly 50 schools and has been recognized multiple times by the Centers for Disease Control and Prevention for its effectiveness in enhancing knowledge about the importance of sun safety, in changing behaviors, and in helping to change attitudes about tanning, etc. And we are very, very pleased to, I think I skipped a slide. We are very pleased to announce that just last week, Governor Sisolak signed into law Senate Bill 159. There we go, here we are, which will now require sun-safe school and school district policies, and recommends that sun safety education be provided in schools. The bill also, importantly, removes the over-the-counter medication designation that sunscreen had, so that it makes it much easier for schools to allow sunscreen to be used on school property and during school activities. It eliminates a barrier so that students have easy access to sunscreen. Nevada Cancer Coalition for the last several years has worked with the Bright Guard company to provide at no cost to schools automatic sunscreen dispensers and a first-year supply of sunscreen, and we are looking forward very much to expanding this program as we move forward. The whole intent of all of this is to hopefully work to reduce those skin cancer incidence rates, and it is again my privilege today to recognize and introduce Dr. Irene Mannering. She is a board certified dermatologist practicing here in Reno at the Skin Cancer and Dermatology Institute. Dr. Mannering is from Minneapolis, Minnesota. She graduated with her medical degree from the University of Missouri Columbia and completed her dermatology residency at the University of California, Irvine. She practiced general dermatology at Kaiser Permanente in Southern California for about 3 years until she moved here last year with her family to begin practice. And with that, Dr. Mannering, take it away.
Thank you.
Thank you.
Very nice.
I'd also like to go around the group real quick and have everyone out there joining us introduce themselves so we can kind of get a sense of who you are, where you're at, and kind of why you're interested in this topic today. So we'll start with up in the upper left corner, C. Carr.
Hi, I'm Hammy Carr with Elko County School District.
Wonderful. Great to have you. Thanks. M. Headley.
Hi, I'm Mary Headley with Elko County School District, school nurses.
Wonderful. Thanks. Pam Forrest. Go ahead, Pam. We should be able
I'm with the state immunization program.
State immunization.
Thanks, Pam. Marlene, if you want to go ahead.
Hi, I'm Marlene Grover. I'm with the Humboldt General Hospital in Winnemucca, a nurse midwife. And, you know, skin is like a major organ. So.
Thanks, Marlene. Good to have you back today.
Thank you.
Somebody joined. It's just a number 15775-73802. I've taken you off mute, so if you could introduce yourself.
Hi, I don't know if that's me. This is Kieran Madden. I'm in Elko, Nevada. I work at the Indian Health Clinic. I've been here for 11 years, and you know, typically I'm somebody that I think would be higher risk for skin cancer, but we have been seeing more and more in Native Americans than I thought we would in the past. So I think I'm looking forward to hearing about it. Thank you.
Great, thanks, Dr. Madden. Jennifer Payette. Looks like you're joined by telephone, so it'll be *6 to unmute yourself. Yep, go ahead.
Hi, I'm Jennifer. Yes, I'm Jennifer Pyatt. I'm a pharmacist in Hobbs, New Mexico, and I'm interested in this program because I actually have a pharmacist that works with me that has had some melanoma in the past, so I've become interested in it from there.
Excellent. Good to have you today. Thank you.
Thank you.
C. Gold. If you're there, if you could just unmute yourself with the microphone icon in the lower left corner of the Zoom window, we'd be able to hear you. Okay, we'll move on. Jan Kalosh.
Hi, I'm the Director of Nursing at Mount Grant Hospital in Hawthorne. I'm a blonde with lots of blonde grandchildren.
Great, good to have you joining us today, Jan. Thank you.
Thank you.
And the last one is somebody called in, 775-772-9720. Could you introduce yourself?
This is Carrie Harrington. I'm actually with Nevada Cancer Coalition, and I'm in the car driving, so my apologies.
No problem. Be safe, Carrie. Thank you. All right, so I just want to invite everybody throughout this presentation, feel free to unmute yourself if you have a question, or there's also a chat box that I'm going to send something out through right now. So you'll see that pop up with a little orange icon. So feel free to write in questions through that as well, and we'd be able to address those. So we'll get going here. All right, go ahead.
Okay. So hi everybody, thanks for taking time out of your schedule to attend this talk. So basically I'd like to just kind of go over the 411 of skin cancers and precancers and kind of so you know how to recognize them, what to do if you come across something that resembles a skin cancer, when to refer, and just kind of also talk about how you treat them in general. So, and then also, like you said, just feel free to interrupt while I'm talking if you have any questions. Okay, so these are the objectives. I won't go through those. Oops, it's kind of touchy. Okay, so skin cancer, I kind of think of it as being in two prongs. There's the melanoma skin cancer and the non-melanoma skin cancer. And this is just kind of a rough division of skin cancer. There are other less rare ones, or more rare skin cancers. But on the left of the screen, you have the melanomas, and then the non-melanoma skin cancers comprise squamous cell carcinoma and basal cell carcinoma. So I'm going to go through each of these and the precursor lesions for squamous cell carcinomas as well. No, it's not. Oh, there we go. Oh, I feel like I missed some slides. Maybe I didn't. Okay. So first I'll go over non-melanoma skin cancer and actinic keratoses. I'm sure if you live anywhere in the Western states, you probably have come across something like this if you're in primary care. Okay, so non-melanoma skin cancer is really common. It is primarily made up of basal cell carcinoma. About 80% of non-melanoma skin cancers are basal cells, and then about 15 to 20% are squamous cells. Basal cell is actually quite common and also probably underreported, so this number might not be correct, but about 25% of all cancers in the US are basal cell skin cancers. So they're really, really common. And so really, they're so common that 1 in 5 Americans will develop skin cancer by the age of 50, and non-melanoma skin cancer. Right. So that's a lot of people. So there's only 4 of us in the room here. So, but anyway, so non-melanoma skin cancers are characterized as being locally aggressive. They rarely will metastasize, and they have a fairly good prognosis as long as you catch them early. So early detection is important to minimize spread and disfigurement. Okay. So actinic keratoses are the precursor lesions for squamous cell carcinoma. They're not going to turn into basal cells. They don't turn into melanomas. These are really, really common, especially in fair-skinned individuals, light eyes, light hair. Also can be seen in people with darker skin. And these will pop up in areas of chronic sun exposure. So in my diagram, you can see really it's the head and neck area and the arms. And these can follow one of 3 paths. So they can spontaneously regress on their own if they're fairly thin. They can persist and really do nothing, but just be there. And some will progress to squamous cells. And the annual progression to squamous cell really depends on the characteristics of the actinic keratosis. So those thicker ones that are more symptomatic will probably be a higher progression rate than the ones that are more thin and less symptomatic. So here are some photos of some some actinic keratoses on these individuals. And these ones are really obvious ones, but sometimes they're just like a little gritty texture to the skin. You can really only feel rather than see. But usually the telltale sign is that they have this hyperkeratosis, which is this like yellow kind of thickened skin, and it's on an erythematous base, so it's kind of red on the bottom. Usually they're asymptomatic, but some will complain of tenderness and stinging, and when those symptoms are present, that kind of tells me that might be more likely to turn into a squamous cell, so I would treat those. There's a version of actinic keratoses that occurs on the lips, and it's called actinic cheilitis. The lower lip gets a lot of sun, and people forget about that. We don't often put sunscreen on our lips. We forget to put chapsticks on that will have SPF. And so you can get a similar precancerous condition. It's just called actinic cheilitis. But these can involve the entire lip, or it can just be like one little spot. And they usually people come and say, oh no, it's not anything, it's just dry skin, don't worry about it. But you can actually look at their lips, they're kind of mottled, they're more kind of pink and white in color, and then you have this chronic roughness to the skin. To the lips. And then the other thing about the actinic cheilitis, it actually has a little higher transformation rate to the squamous cell carcinoma. So if you have one that's more thick and indurated on the lips, you definitely want to treat that and have them come back just to make sure that it did go away. And I'll talk about treatments in a little bit. Actually, right now. So there's various approaches to treating actinic keratoses, and it really just determines on how many actinic keratoses does the person have? Do they have a lot? Just a few? The characteristics of the lesions, are they real thick? Are they thin? Patient preference and tolerance, and treatment availability and cost. So if someone has just one spot, most likely I will treat it with cryosurgery, which is liquid nitrogen. The downside of liquid nitrogen, though, is that it can leave a white spot or a dark spot as it's healing. So some people on the face don't really like to have that, or in the chest area and chronically sun-damaged areas, you'll see kind of it heal as a white color. So some people will just prefer not to use that, but works fairly well. But it's basically destroying the skin that has the actinic keratosis. You blister up, scab, and it goes away. So then there's also field therapy, and those are I reserve for people, one, who don't want the liquid nitrogen, or those that have so many actinic keratoses that it's just unreasonable to use the liquid nitrogen. It's uncomfortable, it's painful. So the most common things that I use are the 5-fluorouracil and photodynamic therapy. Imiquimod can be used as well, but that one is, it's an immune response modulator, so it's going to boost your immune system to kind of recognize that things are abnormal, and you fight off the actinic keratosis that way. But the problem is you can't use that one in a large surface area. You really have to use it in smaller surface areas because you start feeling sick from it. It kind of elicits almost like a flu-like symptom if you use it on a wide surface area. So that's better for small areas, but the 5-fluorouracil works pretty well. It does have quite a bit of a downtime, so people do look spotty. It can be quite uncomfortable. People often don't like me when they're also being treated with this, but it works really well. And then the photodynamic therapy is something that we can offer. You have to use it's a porphyrin molecule that reacts with the skin and then goes into the cells that are only growing faster, and it will be activated by light. So whether or not you have this special machine in your clinic, or you can be treated outdoors. But this one will create like a sunburn-like experience, and then you kind of get flaky and peely over the week or two. So that's a nice one if people kind of want a lower downtime than the 5-fluorouracil. And then there's other options like lasers and peels, but those will not be covered by insurance. So when you see an actinic keratosis, you look at it and you're like, okay, I think this is an actinic keratosis, I'll just freeze it. But you really want to pause and think about, when is this really just an actinic keratosis, and could it be potentially more than that? And the lesions that you want to pause and think about are ones that are larger. So if they're larger than a centimeter, they're indurated, meaning that they're thicker. You can feel it, you touch it, and it feels like it has more substance kind of at the base of the skin. They're growing more rapidly, they're tender, and they fail to respond to like liquid nitrogen or things, and ulcerated lesions. Okay. So before I move on to the squamous cell carcinoma, any questions from anybody, or just keep going? Okay, all right. So squamous cell carcinoma is the second most common type of skin cancer, as I had said earlier, and it's also in the same distribution typically as the actinic keratoses, so in those chronically sun-exposed areas. Same thing also, skin types 1 and 2, those are people who don't burn, people who burn and don't tan, or people who burn and then tan. But you can also get them in people who have darker skin types, especially if they have, they have chronic UV exposure, maybe for their work, they have radiation, they're on immunosuppressants chronically, possibly for, lip transplants. So those are the risk factors for that. And then, as I mentioned, the precursor lesions are the actinic keratosis. So I'm just going to go through a series of photos of various types of squamous cell carcinomas. They kind of run a spectrum where they're thinner, less aggressive, to more poorly differentiated and more aggressive. So this one here is a squamous cell carcinoma in situ. So that means that it's just in the top layers of the skin. It hasn't gone into the dermis. And I didn't put a picture of the skin, but basically the skin is made up of two parts, the epidermis and the dermis. The epidermis is the thinnest most layer, and then you have the dermis with all the blood vessels, nerves, and such, oil glands. So squamous cell in situ is just in the top part. It's just like a step above an actinic keratosis. And so these are usually kind of red and scaly. They are most of the time asymptomatic. They often get mistaken for eczema, sometimes even fungal infections. And how you can, if they don't improve with topical steroids or fungal, and it just kind of sits there forever, it's most likely not one of those things. So you would want to biopsy those, or send it to a dermatologist if you don't do biopsies. So this is, oops, sorry, this is a, well, doesn't want to be on it. There we go. This is a squamous cell carcinoma. This is kind of like your prototypical squamous cell. It pops up fairly fast. It's like a red bump. People often think it's like a pimple or something. They start squeezing it because it grows so fast that sometimes the center kind of looks like it's got stuff in it. But they're hyperkeratotic. They're usually tender and they grow fairly fast, and they're going to be on chronically sun damaged skin like this person. Here's another one. You see kind of this redness, hyperkeratosis, nodule that grows, you know, most of the time they'll say, oh, it just appeared like 2 weeks ago. It's not something that's been really lingering usually. This is one that's on the lip. They can look like this. They can look like the bumps. The lip squamous cells can be more aggressive as well. So you want to treat these a little faster than the ones on the other parts of the body, just because this one can can spread to local lymph nodes a little faster. Then there's this special kind of squamous cell called a keratoacanthoma, or sometimes they're called well-differentiated squamous cells. And these are pretty benign, I guess I would say, but I mean, they're still skin cancer, they need to be treated, but they sometimes regress on their own. But most of the time when I come across one of these, I'll still treat it as though it's a regular squamous cell. So treatment for squamous cell also kind of depends on the characteristics of the lesion, but most of the time you're going to go to an excision, whether or not it's a regular excision or something called Mohs surgery. Mohs surgery is a technique that's used to in areas where you have tissues, don't have a lot of tissue, so like the ears, the nose, the face. Also in cases that might be more aggressive, that you really want to confirm that you have eliminated the lesion at the time of the excision. But you look at the tissue at the time of the surgery under the microscope, then you go back, take more out, and clear it that way. But in cases where they're very large, you may have to do other things like chemotherapy, radiation. In the case of squamous cell in situ, you can do non-invasive treatments like the imiquimod, which I talked about a little bit earlier, in the 5-fluorouracil, which can be intralesional or a topical, and then the photodynamic therapy. But really those are only reserved for very superficial lesions. And the keratogen electrodesiccation, I as well I reserve that for the non-invasive superficial ones. But most of the time you're just gonna go ahead and excise it. So if you don't do excisions, that would be a good referral point to a dermatologist, plastic surgeon, or general surgery, depending on the location and the size. So the prognosis usually is fairly good as long as you're catching these squamous cells in their well-differentiated stage. But if they're large, and they have regional lymph node metastases, the prognosis is fairly poor, 25 to 35%. So really, when you see one of these, it's smaller, it's really good prognosis, greater than 90%. But so I'm just going to quick go over some. Oops, that's weird. There we go. Okay, sorry. Just want to go over some characteristics of, when to kind of recognize that this might be more aggressive squamous cell that can metastasize. And those will be ones that are larger on the extremities, 2 centimeters and above. If they're in the cheeks, forehead, scalp, neck, and kind of the tibial area, over 1 centimeter, and in the mask areas of the face. So that's gonna be like your nose, central kind of face, ears, genitalia. Those ones are ones that really over 6 millimeters you want to, and then other things you see poorly differentiated as a diagnosis from the pathologist, you want to get those out fairly quickly, because those, and then, because those may have like perineural invasion as well, and those are all bad prognostic factors. Okay, so basal cells. So we already talked, very common, most common, 80% of skin cancers. Same thing about sun-exposed areas typically, but these ones tend to occur more in areas of chronic or of intermittent intense sunburns. They're very slow growing, rarely do they metastasize, but if you let them sit on you long enough, they will become locally destructive and disfiguring. And I have patients like that where they didn't want to get surgery when it was small, and then they show up 3-4 years later and it's, you know, taken over their ear, and we're kind of limited surgically what we can do, and we have to, you know, do more advanced treatment. So if you catch it early, it's the best, really good cure rate. So, sorry, there we go. There's several different types of basal cells, and I won't go into all of them, but the most common one you'll come across is most likely the nodular basal cell and the superficial ones, and I'll show you photos of all those. The pigmented basal cells tend to occur in people who are more of like a skin type 3-4, so those are people that are more tan. That might be some of the, I see it, people from, you know, when I was in California, I saw a lot of people who were from Mexico that would be getting them. They worked outdoors long time. They would be getting more of the pigmented ones. And those are a little tricky because they kind of look like moles, but they are growing usually. So that's kind of the telltale sign. Okay, so these are not all nodular basal cells. They are a bump. It can start out like a pimple. And then the characteristic is that the skin is really friable. It's kind of mushy, so it's easily traumatized. So people often think it's just like a little pimple, and they're like, oh, don't worry, it's just a pimple. But then it's like lingering. And sometimes it'll go away or appears to go away completely because it's so easily scraped off. And then it'll come back. So just kind of look for that pearly, translucent character with what we call telangiectasia. So you can kind of see, how do I work this thing?
Yeah, you just move the dot.
This thing?
Yeah.
Okay, so here you can kind of see like these little telangiectasias on there. Here, these little blood vessels you see. And then often there's this central kind of erosion in there. So it's nice classic basal cells. There's another basal cell before it starts to get eroded, but it has those nice blood vessels there that you see. And it's very pearly character. Right, there we go. Then there's another nodular basal cell by the eye. Same thing with little ulcer in the center. Superficial basal cells, they're kind of just like pink. People don't really complain much about these. These are usually just kind of scaly. They might bleed a little bit. I often see these on the trunk. And these ones I will often treat with like a topical cream or maybe the Keratosis desiccation. But these are, people say, oh, no, it's just like a little, I don't know, eczema spot or something, but it doesn't go away. These are morphia formed basal cells. These can be more aggressive. They're kind of scar-like. So you can see that. So these you have to do Mohs or like a very wide excision to clear these. Here's one of those pigmented basal cells, but this one's more advanced. But they're kind of brownish and gray in color. And usually it's just like a little dome-sized papule. But if you look closely with something I'll go over in a little bit, a dermatoscope, you'll see it does still have that kind of pearly character in the telangiectasias. So basal cells really aren't considered like a hereditary skin cancer. It's hereditary in the sense that you have fair skin and your family members have fair skin and you easily burn and the sun isn't really kind to your skin. But there is a hereditary syndrome where people do get basal cells a lot earlier in life, and it's called basal cell nevus syndrome. And these people start presenting with basal cells early, like in their 20s. And they have so many basal cells. It's just like all those little bumps on that person's forehead are all tiny little basal cells. And they have some other characteristics as well, where they have these little pits in their hands, and that's what that photo on the bottom is showing. These little pits here. And they also have some other findings that you can see on x-rays, like they have cysts in their mandible, and they also are known to have medulloblastoma sometimes, and such. So this is really like the only heritable basal cell syndrome versus thing, which we'll talk about. Melanoma is more of a heritable skin cancer. Okay, so treatment for basal cells has a lot of options as well. If it's smaller, so I would say less than a centimeter and it's not really in like the face or the ears, it's more on the trunk area, you can do this electrodesiccation and curettage. This is great, it's quick. What this is basically you take a little curette and you scrape away the skin cancer. And the skin cancer feels different, as I said, than the rest of the skin. It's more mushy. And so you kind of scrape away, then you burn it with a cautery, and then you scrape it. You do that usually about 3 times. And they'll leave a circle scar that kind of heals from the bottom up. So I offer that to people who kind of, they're very active. They don't want to have stitches in. It's a smaller lesion. Some people just want to get it over with and they don't care so much about cosmesis. So that's a good option for them. Surgical excision is great because it tells you if it's gone. So people often want to know for sure that this is gone. So we do surgical excisions. And if it's on the face and those areas there's not a lot of skin, the Mohs is great for basal cells. It provides the highest cure rate as well. It's just that certain areas, you don't really need to do Mohs. You don't need to do Mohs necessarily on a trunk because you have a lot of tissue to move around. But if it was, a lesion that was recurrent or something, then maybe it'd be more appropriate for Mohs. And then a Mako model, just talk again about, that's great for the superficial basal cells and low risk sites. It gets really, really red and angry, so you just have to let your patients know that this is the expected response that you want. It means that it's working. And then in cases where it's real advanced, which I do have a patient on a Domzo right now, where it's just you cannot resect it, it's too huge, and possibly they have metastatic involvement. These are oral medications that are blocking the patch pathway, which is known to be activated in basal cells. And these have some terrible side effects, mostly your taste. You just don't want to eat, and so you lose weight. But I have a patient on that right now, and it's very challenging to have them on that and keep them on it because of the side effects. So hopefully you never have a patient that you have to put them on that.
How long would you have to maintain that?
Well, that's the question. So the gentleman I have on it right now has been on it for 9 months. We've been watching the basal cell shrink, but it's still there. And so then it's a point, do you try to excise it now that it's smaller? And he's kind of had it with the side effects. So you get to a point, and sometimes I haven't used this one. That one's a newer one. But the Vismodegib is a little older. I saw that one in residency. And sometimes it just stops working, and then you stop it. But oftentimes, I've had people stop because of they're losing weight and the taste. They lose their sense of taste. So. Okay, so I'm going to switch gears now to the pigmented lesions. So we're going to go to the atypical nevi and melanomas. So melanocytic proliferations are on a spectrum from benign nevi, which is just your standard mole, to melanoma. And then in the middle in this gray area, you have these atypical nevi. And we classify them as mild, moderate, severe, and whether or not mild, moderate, or severe is going to turn into melanoma is very controversial, but probably more likely in a severely atypical mole. So I'll kind of talk about that a little bit more. So atypical nevi, this person on the right has several moles that are enlarged. They don't really quite look symmetric. They're larger, they have irregular borders, so they share features of melanoma, but this person's loaded with them. And so most likely not all of those are bad guys. And these are usually familial, and so other people in the family will have similar characteristics of moles. And it's about 10% of the population, fair-skinned individuals, will be characterized as having atypical nevi like this. So atypical nevi are not necessarily precursors to melanoma. Some melanomas will arise from pre-existing nevi, but most will arise de novo, meaning brand new. And so, but if you do have a lot of atypical nevi, your risk for melanoma is higher than the average person. So that on the left you have the common mole, very symmetric, even pigment colors, pigmentation, and then on the three on the right side you have the atypical moles with variation in pigmentation, size, borders. So how do we identify melanoma? So we've got all these people with atypical nevi, people have moles all over them. So they've come up with the ABCDs of melanoma, which aren't totally inclusive of all melanomas, but they do help guide us kind of on what to look for. So A is for asymmetry, so you can see that this mole, you can't cut it in half and make it look the same in any direction. The borders are irregular, they're notched here. You can see it looks like it's trying to grow. The color, there's lots of colors in this mole. There's dark browns, there's black colors, there's even reds and whites. And then it's larger than a pencil eraser diameter usually. And then the evolution or evolving category is it starts out as this nice little brown kind of macule. Maybe you just think it's a small sunspot called solar lentigo. But then you notice it's starting to enlarge, and then it's getting bigger and darker. So anything in those categories you would want to biopsy or send for further evaluation with the dermatologist. Another way you can kind of evaluate for melanoma is something called the ugly duckling sign. So this person has a lot of moles. You kind of look at all their moles, and then you find one mole that looks nothing like the rest of them. This one's a tiny mole, but it didn't look anything like the rest, and it ended up being a melanoma in situ. And so that's one way is you kind of look at the pattern of all the moles, and if one stands out, you might want to biopsy that one. Another tool you can use that I find really helpful is called dermoscopy. And so dermoscopy allows us to see the pigment pattern of moles more clearly, and different patterns can indicate growth and melanoma, like possibly a melanoma. So dermoscopy in the center there is one, a dermatoscope. There's lots of different ones you can buy, but basically it magnifies it, and then whether or not you have a feature of polarizing light or not, some have that, some don't. But on the left you have a mole without the dermoscopy, and then this one you have a mole with the dermoscopy. So you can see the pigment pattern much better. You can see better what's going on here. There's this darker pigment at the periphery. There's a little cluster forming there. And then this is kind of more just like a generalized reticular pattern. You may be able to see that over here on this side, but you just can't quite appreciate what's going on as well. So I'm just gonna, I don't know if anybody uses dermoscopy, but here are some benign patterns that you'll see in just kind of regular old moles. And the main thing is, this nice, a lot of moles will just have this reticular kind of uniform pattern. Some will have kind of a uniform globular pattern. This one is just dark in the center, patchy reticular, and then where we have a hypopigmentation with the reticular pattern on the periphery, and then kind of combinations of that. But the characteristic of all of these is that they're fairly symmetric pigment patterns. Even though these moles might look funny to the gross eye, when you look at it more closely, they're really quite uniform. They have the same pattern throughout. So now these are atypical pigment patterns that are associated with melanoma. So what I look for mostly is, it's okay to have pigment that's kind of different in the center, but if you start seeing it on the edges, like here and in this one, that can be a sign, and here, that can be a sign that it's starting to grow, and that maybe this could be a melanoma. Also, dark globules, just kind of irregularly placed, and more prominent blood vessels can be a sign of melanoma as well. And then here are more globules that are just kind of peripherally placed, and then another one where it's just really dark, kind of hazy area, and on dermoscopy, it actually looks kind of like a white-gray kind of veil. So whenever I see anything like that, or pigment at the side, the periphery, doesn't look like any of the other moles, I biopsy that one. So we talked a little bit about the epidemiology of skin cancer and melanoma, but melanoma is on the rise, and it's, we don't really know why, but it's definitely increasing incidence, especially in men, older adults. It's estimated that 1 in 50 Americans will develop melanoma in their lifetime. And so there's a number of risk factors. Genetics, so if you have a family history of melanoma, specifically like in a first-degree relative, brother, sister, mother, father, you really should be, and you have a lot of moles, you should be getting regular skin checks. Lightly pigmented skin, your tendency is to burn, and you have red hair color. Other things is, chronic sun exposure, tanning booth use. We now know tanning booths are a known carcinogen, like a cigarette. It causes skin cancer. A lot of tanning booth use, especially before the age of 35, increases your risk for melanoma. Also, people with a lot of, a lot of atypical nevi, they are at higher risk, and people with a lot of moles, like greater than 100, they're going to be at an 8 to 10-fold increased risk. So those are people that you want to see more on a regular basis as well. And those people are hard because they have so many moles, so it's kind of hard to keep track of what moles are changing and what aren't. So what I often tell people is, if you don't have the capability to take photos in your clinic, one thing you can tell them is, you know, take photos with your cell phone, and then always have the same person or the same distance when you're taking the photos, and then repeat it monthly, and then compare the moles and see if there's any new ones. There's also professionalists that will do body mole mapping as well. So sometimes you have to do that in those people that have so many moles. And if you're out in rural areas, oftentimes you kind of have to rely on the patient to take photos, and it just remind them to check their moles monthly, take photos of any ones that they think are changing, and do that. So, let's see. Okay, and then there's also like basal cells and squamous cells. There's subtypes, and some are more aggressive than others. And so the most common one is the superficial spreading melanoma. And then lentigo maligna melanoma is one where we see it kind of emerging from a thinner type of melanoma on a sun-exposed area. And I'll go through all these more detail, but superficial spreading melanoma is the most common one we see. So you can see, so superficial spreading melanomas are more like this one, where they kind of go outward first before they go downward. So you're trying to catch them before they really go deep into the, so this is that dermis I was talking about. So we want to catch them before they go into the dermis, because the deeper they go into the dermis, like on this, now you're having the radial or the vertical growth phase, the higher the risk for metastases. So earlier detection, better. So the nodular melanomas, we don't want to get to that stage. Oops. Sorry, can we go back to this? There we go. Okay, so this is a very nice looking melanoma in the sense that it's like your stereotypical melanoma. This is a superficial spreading melanoma. It's usually in men, you'll see the melanomas like this on the trunk. In women, you'll see them in the legs. Nodular melanoma is the second most common one. These don't have that kind of radial phase, they just go down. And these are really hard to catch early because they grow super fast, but they're usually a dark kind of bump. Some people will tell me that they kind of hurt or itch a little bit, and you just want to take these off. But usually when I see these, they most likely will get a lymph node analysis as well. Oh, sorry, one more. I'm going to do it. Yeah, there you go. Lentigo maligna melanoma is about 10% of melanomas. This one's going to be in chronically sun-exposed areas. So you start out as like a brown spot that looks like a sunspot, and then you're starting to watch it it starts growing. It's larger. It's the coloring is more variable. And so lentigo maligna is a melanoma that's in situ, meaning that it's just in the epidermis and it's in that like horizontal kind of superficial phase. But if you let it sit there long enough, it could potentially get into lentigo maligna melanoma, which has the vertical phase. So now it's going down into the dermis and it has the potential to metastasize. These are fairly slow growing, especially, and if you get it in the lentigo maligna phase, the treatment is you cut it out and the cure rate is like over 95%. So you want to catch it in that phase. But really any large brown spot I see on someone's cheek that is kind of variable in color, I watch very closely. And they often say, oh, it's been there forever. But yes, it's been there forever, but it might also be an early melanoma. So I have a low threshold for biopsying ones like this. So this is another one where it starts out, probably it started out just like a lentigo looking thing, and then over time, years, it started to evolve into this lesion. And then, sorry, I'll stop pressing it, or do you want me to?
No, you can keep
Okay,
going.
sorry. So
Okay.
acral lentiginous melanoma is melanoma of like the finger, the digits, the nails. So that's the one that Bob Marley passed away from. So these are not really common. It's only about 5% of them, but if they do occur, they're often quite aggressive or they're caught late. And so things to look for these is you have, this band of pigmentation. And if that band of pigmentation is larger than 3 millimeters, really you should warrant a biopsy. Also, if it's the only nail that has it. Sometimes people just have physiological longitudinal melanonychia, which is, brown stripes. Maybe it's induced by medication, an endocrine problem. But this one is darker, and then it also has some pigmentation on the skin, just like this one. Or sorry, it's wider and has pigmentation that carries onto the skin. Same with this one. Pigmentation's on the skin, and this is fairly wide. And then this one is on the bottoms of the feet. So I always check people's feet between the toes and on the bottom of the feet, and people always say, why are you doing that? Well, because you have moles on the bottom of your feet. So they get missed because people don't realize they have moles on their feet. So we need to, remind people to check their feet every once in a while. This special sign of it, the pigment being on the skin there at the proximal nail fold is called Hutchinson sign. So if you see something like that where it looks like the pigment is on that proximal nail fold, definitely needs a biopsy. And then there's this kind of other melanoma that doesn't follow any of the rules. It's usually pink. It's called an amelanotic melanoma, so it doesn't have the pigment. I've had a couple of these, not here in Reno yet, but I've had them in California. And they look like a regular mole or just nothing really very suspicious. But if you look really closely, which these photos, I'm not sure if this one really shows it too well, but you can see sometimes, like with your dermatoscope, a light kind of pigmentation around the rim sometimes, and that's kind of a clue to me that, this might be a melanoma. So look for a little kind of rim of some sort of pigmentation occurring if there is this pink bump that's kind of rapidly growing in front of your eyes. So treatment for melanoma, if it's a superficial spreading one, less than probably. So the cutoff for when you're, let's say it's localized and it's not very deep, you would do a wide local excision plus or minus an examination of the lymph nodes. The lymph nodes, the depth is anywhere from 0.7 to 1, 0.7 to 1 millimeter, and that whether or not you're going to go for nodes at a lower depth is dependent on the characteristics of that melanoma. Does it have lymphatic invasion appearing on the pathology? Does it have high mitotic rate? This is kind of an evolution now too. I think they just revised all the criteria, but if you have some of those characteristics, you might do lymph node analysis a little earlier than if it was at 1 centimeter, which is kind of like, 1 millimeter, which is more the traditional. And then in metastatic or unresectable melanomas, we have some targeted therapies. There's the BRAF inhibitors, which target a mutation at V600, and then there's MEK inhibitors, which I'm going to just quick give you an overview of this pathway in a minute. So those are blocking a pathway that is known in most melanomas to be abnormal. And then there's also immunotherapy agents, which I'll talk a little bit more in just a minute as well. So over probably the last 10 years, we've really had a lot of excitement around melanoma and really understanding its molecular biology and its genetics. And what we found is this mitogen activated protein kinase pathway is activated in most melanomas. And specifically the BRAF is found, oncogene is found in about 40 to 50% of melanomas. And so that offers an opportunity for targeted therapy blocking that BRAF oncogene. And so that's going to be like your verapamil and some of the other medications. And then further downstream, you have the MEK area. And so the MEK inhibitors will block a little further. And so the BRAF and the MEK inhibitors are often used in conjunction together. Sometimes they're used just the BRAF, but oftentimes the tumor gets smart and you have to add a MEK in there. But I don't obviously prescribe these. This is oncology, but just to give you some ideas about some of the medications and where we're at. We're targeting the actual mutations of melanoma now, so it's very exciting. And then the other kind of way to treat melanoma too is that tumor cells get smart and they learn how to evade our immune system. And so they work on pathways to hide so that our own cells don't recognize that these are tumor cells. So there's these CTLA-4 and PD-1 inhibitors, which augment that anti-tumor immune response that the melanoma is triggering. And so those are ipilimumab and nivolumab. And so these are very powerful agents that work quite well, and I'm going to show you an example of one in just a minute. But the timeline for FDA approval for metastatic melanoma, like our treatments were really limited for many, many years. We just had a little bit of chemotherapy, and then we had high-dose IL-2, which is trying to boost the immune system to fight off the melanoma. But then this surge happened after 2010 when we really started to understand the molecular genetics of melanoma, and all these new medications have come out, and there's probably even more. I just didn't list them here, but it's a very exciting time in melanoma treatment for advanced melanomas because we're better understanding why melanoma is happening, and so we're able to create more targeted therapies. So this is an example of a lady who was given ipilimumab and nivolumab for a very large melanoma that was, had advanced I don't know how to move that dot. Advanced metastatic melanoma. So in the scan, you can see that it's involving her internal organs. Well, she was given this combination, and she came back and she said the tumor's gone, and she also had a cavity, and it eliminated. It worked so well that it kind of just ate up the rest of her inside. So she's just left with this cavity. So this was a quote from this article. It's ironic now that we are now concerned about the possibility of overly vigorous anti-melanoma responses. And so what I see sometimes in people who are coming from oncology and I'm doing their skin checks is they have a lot of people that are on these immunomodulating medications. They have more problems with like endocrine, so they'll have pituitary problems, things like that. So you have to watch that. But it really boosts the immune system. Just goes in overdrive, and it kind of so. And then this is just a reminder, tanning beds, select your skin cancer, basal cell, squamous cell, or melanoma. You'll get it if you keep going. So any questions or anything, comments, concerns?
Yeah, any questions out there, feel free to unmute yourself or write in through the chat box.
And I won't touch this thing.
Okay.
Alrighty, they can see that now.
Okay, hi everyone, this is Christine again. I just would like to remind you that the Nevada Cancer Control Summit, which Nevada Cancer Control hosts every year, will be this year on Monday, September 16th here in Reno at Whitney Peak Hotel. One of Dr. Mannering's colleagues, Dr. Whitney Hovanek, will be presenting about skin cancer and some of the latest treatments for that, as well as just a wealth of other information on all things cancer. So please, you can visit nevadacancercoalition.org and /summit to get more information about the agenda for that day. And we hope to see you there. And thank each and every one of you for participating today. And thank you again to Dr. Mannering for being here.
Thank you.
Thanks everyone, take care.